I'm gonna let you two start on the interest of time. Thank you, everyone.
Welcome, everyone. If you're just joining the Stop the Stigma conference, I want to warmly welcome you to this session entitled Medical Neglect and Accommodation Failures in Prison. I will kind of host as the moderator for this session, and I will be joined by Dr. Laura Hawks and Dr. Stanley Andres. This is a critical conversation about healthcare access, systemic breakdowns, and lived consequences. As I stated, this is the Stop the Stigma conference that is hosted this year by the community and Moxie Educational Services. At Stop the Stigma, we acknowledge the importance of person first language because language shapes how we understand one another. Person first language centers our humanity and reflects our shared commitment to dignity, respect, and equity. We also recognize that individuals may prefer identity first language, and we encourage speakers and participants to honor personal preference whenever possible. I'd also like to begin with the land acknowledgement. Although this conference is held virtually, we acknowledge the indigenous peoples whose lands we occupy as we gather, learn, and collaborate. The community, headquartered in Milwaukee, Wisconsin, is on the traditional homelands of the Hunchak Nation, the Mennonite Nation, and the Potawatomi Nation with enduring ties to the Obiji Ottawa peoples of the Council of the Three Fires. Moxie Educational Services is based in New Hampshire on the ancestral lands of the Abenaki and Pennacook peoples whose histories, cultures, and sovereignty continue today. We honor their resilience, ongoing contributions, and enduring relationship to the land. This acknowledgement is only a beginning. We encourage all attendees to learn about the indigenous nations whose lands they reside on and to support ongoing efforts toward indigenous justice and sovereignty. Accessibility is a shared responsibility. Thank you for helping create a conference culture rooted in respect, care, and openness. ASL interpreters are provided for each session and court captions are activated. I'm Dr. Chris Matthews. I am a Black male with a beard. I'm also bald. I am wearing a blue shirt with a tan-ish sports coat jacket. I am joining this conference today from my home office. I have a window to my right that I'm able to look out and see the snow. Dr. Laura Hawks, would you mind giving us a visual description of yourself?
Sure. I am a white woman. I have dark brown hair that is somewhat curly, particularly curly today. It must be humid. And I am sitting in my basement office. It's a little cold down here, and there are no windows. My background is blurred, but there is a map of the world behind me. And I think I will pass it to Dr. Andres.
Hello, everyone. Hope you can hear me okay. Thumbs up if that is the case, because this is my first mic check. Sorry for my tardiness. And I am in my vehicle. My daughter spiked a fever and had to stay home from school, and just kind of threw off my day a little bit. So my apologies. I am on the call here while driving. My eyes will be focused on the road. I promise to stay safe. But I am a Black male. Um, I have my Be More, my Baltimore hoodie on, with my 7-year-old daughter who looks like has fallen asleep, and you can't really see her because I have my university, which I will talk a little bit about. In my conversation as my backdrop, Howard University College of Medicine. is the backdrop of my Zoom image. But pleasure to be here with you all. And do I pass it back to you, Dr. Matthews?
Yes, thank you, thank you, thank you. And please keep those eyes on the road, eyes on the road. Thank you both for joining for this timely conversation. Throughout today, through Stop the Stigma, we've heard various presenters and panelists discuss how they have been personally impacted by medical neglect, whether they were incarcerated or post-carceration. Really, I would like to start our conversation today from hearing from the both of you, really around this overall theme of privacy, dignity, and disability. So, how does the public handling of medical needs, such as the correctional officers announcing conditions, medications, or appointments, uniquely harm people with disabilities, especially the deaf, cognitively disabled, or mentally ill individuals? Any comments on that particular aspect?
Yeah, certainly. I'll chime in, and since Dr. Andrews, you're driving, but just let me know, raise your hand when you want me to tap out. I will speak a little bit from my understanding. I have not been incarcerated myself, so my understanding talking to patients and other people who've been incarcerated who may or may not have a disability. Um, so very pertinent to people who identify as deaf, cannot hear. Oftentimes, the way that medications are dispersed in the carceral setting requires being able to hear the call, the bell, the people coming around telling you that it's time. And so, if you can't hear that and you don't have another way of being informed, it is a reasonable possibility that you would miss your medication altogether. So that's one example among many, I'm sure. Um, uh, Similarly, people who may have certain medical conditions that they would like to keep private can also have that privacy eroded while they're incarcerated. Um, um, I don't know if this is as common anymore, but in the early 2000s, early 2010s, people with HIV in some prisons would get their medications separately from everybody else. And so they would have to stand up into the line and sort of be identified in that sense. Again, I don't mean to be perpetuating any stigma around HIV. I don't think that is something that anyone should be ashamed of, but certainly everyone has a right to their own medical privacy, regardless of their medical condition. And similarly, now I heard I was speaking with someone from Massachusetts where they really expanded access to medications for opioid use disorder in the carceral settings. But again, there's no way to receive those medications in a private way. So people who are receiving methadone show up in one line, people who are receiving Suboxone or a different formulation of buprenorphine show up in another line. And if your substance use is something that you wanted to keep personal, and the treatment you're receiving for it, again, I'm very glad those medications are offered in prison. But there should be an opportunity for all people to receive their medications in a way that maintains their privacy, and which is what we expect of all patients in the community setting.
Thank you. Thank you.
If I might add to that, if that's okay. So yeah, I think I agree, and thank you for sharing all that you just shared there. And for me, coming at it from the lived experience perspective, and also just to maybe spend just a quick 60 seconds on my background. So I am a formerly incarcerated person with 3 felony convictions. I was sentenced to 10 years in prison. Was looking at life in prison. Had a prosecutor pushing for life because she felt that this young black male from the Ferguson area had no hope for change. Fast forward some time, I did my time. I'm now Dr. Stan Andrees, endocrinologist scientist, and recently tenured associate professor at Howard University College of Medicine. Also was at Johns Hopkins Medicine for some time in pediatric endocrinology, and also took my talents across the seas to a place called Imperial College London. Um, but so coming at it from the lived experience lens, I can recall, just as Dr. Hawks was mentioning, um, that there's no privacy in it. And the piece that I would add to it is that I can recall, and even myself, you know, having, there was a stigma. Like we knew who was on all the various different types of medications, and we felt some type of way, including my less knowledgeable self, uh, can recall knowing what everybody was on, and having certain types of feelings, because I have that knowledge, and others have that knowledge. So I can definitely, and I mean it. I was the type of person in my, I recently wrote a book where I talk a little bit more about this particular experience. But um, I wasn't the person that, I didn't join any gangs. I kind of hung out with everybody. Um, and partly because some of the folks particularly got targeted for this. So I mean, the system was actually creating opportunity for people to be targeted in a harmful and negative way. So just want to add that piece to what Dr. Hawks added.
Yeah, thank you for that. I appreciate those comments, and it really got me to thinking, do you feel medical privacy can even be accomplished in a carceral setting? And if so, what would that look like?
I don't know that it can be. Certainly, I think there could be improvements made. And I would even go so far as to say that it is oftentimes that when people are brought to a community hospital the under correctional control, their medical privacy is still becomes uh, uh, unimportant or less important, right? So if I'm a provider, and I don't care for as many patients under correctional control right now because I see patients in a clinic, but I was just speaking to an emergency room doctor yesterday, who was caring for a patient with a very personal medical issue involving their genitalia. And he was a student, but he was seeing the patient on his own, and he was telling me he didn't tell the correctional officers to leave the room when he was doing the physical exam because he felt like he couldn't. And I tried to encourage him to know that in the future he could, but I also feel a lot of empathy for that moment when you feel like you're not really empowered to. So there is a deference of medical providers to correctional officers. We tend to be rule followers. And so I think even in the carceral setting, that would be exacerbated or just as common, right? When people should really just have a one-on-one with a physician, that the correctional officers are almost always exposed to whatever is going on in that room, and the results of the encounter as well. So what's ordered, what labs came back which way, and so I would say I think protections could be added, and part of it is like a huge cultural shift in medicine not being so deferent to um to whatever correctional officers tell them or law enforcement officers tell them. And then also sort of setting up those additional safeguards in prisons and jails.
Right, right, right. Thank you for that. Dr. Andres, anything to add with on that particular topic?
Yeah, I would just like to add, a couple years back, the nonprofit that I co-founded, From Prison Cells to PhD, which I see May Simmons just dropped the link in. I can't really check the chat. I don't know why she dropped it, but I did just see that pop up. Um, but the nonprofit was awarded a $12 million 10-year contract with the National Institutes of Health to start a project where we were going to pilot in Maryland and Missouri prisons where people we were looking to improve upon telehealth services, and we envisioned um, and we got awarded money to provide individuals their own individual or possibly a shared tablet that is specifically used tablet or laptop that would be used for telehealth sessions. And we envisioned it being in the person's cell or in a private room. And then we also envisioned to where it was almost like, that we can set up Amazon deliveries to where the person, has this meeting with their provider and and in private and is prescribed some type of medication, and the medication gets delivered to them, um, you know, without, that packaged up to where it is not, you know, known by the person delivering it. There were some complications to that particular aspect, and I mean, you know, this was unfortunately, I'm kind of speaking pipe dreams now. We were about 2.5 years in, and Doge actually came and cut that project. So, this project that I'm speaking to you of, we were in the midst of making it happen, but it just, I mean, it got cut by Doge. But I mean, I believe your question was, do you envision a way to make it more private? And I mean, we were seeking, and we had envisioned a way. Uh, it could be more of a private experience for individuals.
Yeah.
You
Thank you for that,
know,
Dr. Idris.
those fundings.
Thank you for that. Just want to let you know in the chat, you do have some fan club members that are joining us today. I want to kind of shift our conversation a little bit. In January of 2025, so just about 1 year ago, the Vera Institute posted an article on their website. And I just want to read the first sentence of that article where it states, each year that someone spends in prison cuts their life expectancy by 2 years. Mass incarceration multiplies that impact on a societal level. If not for incarceration, the U.S. life expectancy would be 5 years higher. So obviously, the lack of medical attention while incarcerated has a cost. I want to shift our conversation a little bit to discuss kind of the financial cost of that. So the cost of being sick, not able to get the right access to the medication you need or to the services that you need. How do medical copays function as a deterrent for disabled people who need frequent care? Dr. Hawks, would you like to kick us off on that?
Sure. Yeah. So I realized I never introduced myself either. So let me do that really fast. Sorry. And then I'll pop in. My name is Laura Hawks, as you all know now. And I'm a general internist with the Medical College of Wisconsin. I am a practicing internist, so I see patients 1 day a week, and I'm NIH funded to do health equity, health services research. So I mainly focus on the ways that intersecting with the criminal legal system impacts health, particularly interested in improving outcomes for folks with chronic disease as they reenter, but certainly am excited to be involved in some projects for folks while they're still looking at health while people are still incarcerated. I do not have a lived experience of incarceration, as I mentioned before. I do have a close family member who's been incarcerated, and so I do have some experience living with someone who is sort of experiencing the consequences of having that felony conviction on their record. Okay, back to the question at hand. So copays. So every state has its own prison system. That's something that is kind of important to this conversation generally. And there's unlike all of the healthcare systems that you and I may interact with as patients, the healthcare systems managed by the states are not really subject to any degree of accreditation because there's no sort of governing body. The thing that keeps all of the community-based healthcare systems accountable to holding a certain level of care is that they virtually all receive money from reimbursement from Medicare, and Medicare has very high standards of care that they enforce in order to receive those funds. And actually, it is illegal for Medicare and Medicaid funds to be used during incarceration. There is an exception to that right now. That's in the last couple of years. But for the most part, Medicare, CMS, the governing body um, for keeping these healthcare systems accountable, does not intersect with the state prison systems and their healthcare at all. And so there really is no body that's responsible for ensuring high quality medical care. And on top of that, we see that every state has a different way that it manages providing healthcare services to the people who are incarcerated in their system. So we we in Milwaukee, I mean in Wisconsin here, if you want to see a healthcare provider, you get charged $7.50. So again, as people who aren't currently incarcerated, we might dream of a $7.50 copay. That's not that bad, but when you think about the salary or the hourly wages during incarceration in Wisconsin, we're talking like on average between 30 and 60 cents an hour. So this is multiple weeks worth of work to see a healthcare provider. And in some states, there's no copay at all. In some states that there is a copay, but it's much less than in a place like Wisconsin. There was a study a couple of years ago that was published looking at data from 2016, and it compared the rates at which people sought care by the state that they lived in and whether or not they lived in a no copay, a small copay, or a high copay state. And what they found is this sort of dose response relationship. So people in states with no copay sought the most care, people in states with low copay sought the medium amount of care, and people in states with high copays sought the highest amount or the least amount of care. They deferred care the most. And so there were no like medical outcomes in that study, so we don't know exactly how it was impacting health. But as I'm sure everyone on this call can imagine, when you are scared to go to the doctor because you don't want to go into debt or because you need to spend money on something else, like deodorant, then you're likely to defer things that are only going to get worse, and are likely to get more expensive and likely to make be conditions that are harder to treat. So we know that that is a problem. There is not a lot that's being done to address it. In Wisconsin, they've talked multiple times about reducing the copay, but it's really never caught traction in terms of like an actual policy change. And then just to sort of drive home the connection to the conference, which is that we know people with disabilities need to seek care more often, and they should be able to seek that care without having additional burden of cost. So if for whatever harm is conferred by these high levels of copays, it's going to be highly concentrated among populations of people with just about any disability who should be seeking care, who should be seeing the doctor more often for that healthy preventive care to be well, and are going to be deferring it at even higher rates and in times that are probably even more important than folks who don't have that disability.
Thank you for that. That was really some deep insight for us. Dr. Andres, anything to add?
Yes, I am not a practicing clinician as Dr. Hawks, so don't can't have that perspective that she just very nicely provided us. What I would just like to add briefly is just a plug to a project, and I think she may have kind of hinted to it a project that Dr. Hawks is part of. So we, recently we were approached by me and a colleague, endocrinologist colleague, were approached by Springer to produce a book on endocrine care in prisons and jails. And we've gathered a group of experts from across the country that are in this space, including Dr. Hawks, to, really take even a deep dive into questions like what you just asked. And I believe, Dr. Hawks, your chapter will be talking a little bit on that topic, if I recall correctly. So I would say just coming soon. We hope that would shed some light. I don't know if you want to talk a little bit about that.
Can we
You
get a
know,
little sneak peek, Dr. Hawk?
Yeah, certainly. I mean, I don't have a whole lot else to say on the copay issue. That's sort of the extent of my knowledge on it. I mean, I do think one like pipe dream that I have in the same way that we have funds to help people um, uh, with like bail funds is like having a fund to help people cover people's copays when they need to seek medical care in the prison system. That's like a pipe dream. It does not have legs at the moment, but like I think that would be something because again, $7.50 is a lot less money to somebody who's not incarcerated. That being able to raise some funds to help cover those copays, I think would go a long way. Obviously, the true systemic, necessary change is to eliminate the copay. Right now in Wisconsin, we have really tough legislature for making those kinds of policy changes. Um, I guess I sort of touched on this, and this is something we go into in the book, or I just touched on this. It's less related to the copays, but when we think about holding healthcare systems accountable, um, um, you know, by law, people who are incarcerated are sort of this unique population because there is actually a Supreme Court of the United States ruling that they are literally the only population in the country that has constitutional right to health care. There was a ruling in 1976, Estelle v. Gamble, that stated that the deliberate indifference to somebody's healthcare needs constituted cruel and unusual punishment. That's all well and good. But as I just mentioned, there's no governing body to enforce that. And I know that you would boo me off the stage right now if I said, well, so great, the problem solved. Everyone has health care. And again, because there is no governing body, there's no legislation to enforce that. There's no executive branch administration that oversees it. The only way for people to actually attempt to receive standard care while they're incarcerated is via the courts. And that has just been proven time and time again to be extremely ineffective. Even when you have a good result, it oftentimes takes 10, 15 years to get the result that you need, that the constitutionally guaranteed result. So in California, I believe it was 2011, the Supreme Court again ruled that due to this earlier ruling, the state of California was essentially ish, holding an unconstitutional or overseeing an unconstitutional system because it was so overcrowded that people couldn't get the health care that they needed. It was deliberate indifference to their healthcare needs. Therefore, the Supreme Court actually said the state has to decarcerate. They were somewhere over between 200 and 300% of capacity at the time. And the Supreme Court ruling said they have to get down to 140%. So they didn't even say you have to get to 100%. Like you could still operate above capacity. It just has to be less above capacity. Now, what's notable about that is that it took 10 years from the first time that the lawsuit was brought to a court before it was actually ruled on by the Supreme Court. And the ruling cited that a person died in the state prison system every 5 to 6 days of preventable causes during that time. So if you do the math there, that's hundreds of people who died while they were waiting for the Supreme Court ruling, relying on the courts to um, uh, provide standard of care is just it's not going to get people the needs the results that they need. Especially now we know like having a Supreme Court that's far less favorable to the rights of people. We need a different system to hold the carceral healthcare systems accountable.
Yeah, man. you made a point about the systemic change that is needed, and the current system that we're operating in is definitely detrimental to those that are incarcerated. Those that are just living out in society, we also struggle with, healthcare coverage, health in general, and to have an individual that is in that carceral space just kind of adds to that. Just they're been unable to effectively and officially, take care of themselves. At the opening of Stop the Stigma yesterday evening, we had the opportunity to view a film, Being Michelle. And it was really interesting for me to kind of hear from her experience when she was dealing with the justice system, in and out in prison, having to deal with medical issues, struggling, not being able to kind of get to appointments effectively. Uh, I want to kind of shift our conversation a little bit to spend some time discussing the impact of chronic illness and slow violence. And so, how are long term, life threatening conditions such as cancer, diabetes, neurological disorders deprioritized or ignored in prisons?
I haven't, Stan, do you want to take this, or I'm happy to talk too?
If you wanted to go first, you could go first, or
Yeah.
I could go first. Yeah.
That's good. Yeah, so we are talking about my favorite topic now, which is chronic disease. So chronic disease is something that you need to have preventive care to manage. So as a primary care doctor, I spent a lot of time with people who did not control their blood pressure, did not have access to that care when they needed it, and now have a lot of the downstream consequences. They've had a stroke that's debilitating. They've had a heart attack. They're progressing near kidney disease, and those are all things that are preventable, not always preventable, but many of we know how to get those risk factors under control to prevent many of those cases. And so, I think that again, when we do things like instill copays or reduce, have barriers in terms of privacy that reduce people's likelihood of seeking care because they don't want their business out in the world, understandably so. We're just sort of layering on top of all of the other reasons why people don't get their blood pressure under control, which again happens both in the prison and out of the prison. But when we just add a barrier after barrier after barrier, we know that there's going to be downstream consequences of that, and oftentimes they're irreversible. So this is also true of cancer. I think you mentioned that, and as an issue, that not being able to have access to screening is a big problem. So colon cancer screening is super important. We know we can catch most colon cancers before they become deadly. But you have to do a colonoscopy, which is not an easy thing to arrange. And so not if someone's incarcerated for 20 years between the age of 40 and 60, they may have missed their window to have that colon cancer caught at a time when it can be treated. And cured. And so actually there was some studies that came out of Connecticut a couple years ago, which showed that people were being diagnosed with advanced stage cancers in the year after release from incarceration at much higher rates than the general population, which is sort of supporting that hypothesis that by deferring care, people are being put at risk for having missed their opportunity to have cancer caught in the early stages. So I could probably give you examples like this for almost every medical condition. But as someone who is a preventive medicine doctor by training, it is sort of the most important thing that we oftentimes miss.
Thank you.
Yes, and if I could just plug our book once more on this, because we talked pretty extensively on this topic. So again, should be coming out sometime early 27. But endocrine care in prisons and jail, there hasn't been a book that really looks at that topic. And of course, we're kind of looking at it from a focus on endocrine, but um, really looking at healthcare as a whole. But I just want to highlight one of the chapters by one of the authors is a currently incarcerated transgender woman, uh, and another author is a currently incarcerated transgender man. Um, and both of them share stories of going to the chronic to the issue of chronic uh, disease. A big part of it is preventative care and consistent care. The consistent piece is very, I mean, preventative and consistent is very difficult in carceral settings. So they share a story of in terms of transgender care, the medications that they need, um, that they requires a level of near precision consistency. And it was they shared just a quite traumatic experience of and dangerous experience of when when these particular medications that are provided for individuals transitioning, uh, not being provided the right dose can literally be very harmful. And the individual explains how through correctional barriers, through corrections just creating barriers for their clinical providers, they had to ration off the medication that they were given, and by doing so, by taking this lesser amount, was literally putting themselves in serious harm's way, and not getting the proper care that they're supposed to be getting. So I think part of the problem with chronic disease and is this inconsistency of being able to get access to their medications, and it almost being intentional. In these cases, it was an intentionality behind the correctional staff having a stigma towards transgender individuals, and so put them in this situation where they were literally in harm's way because they weren't getting the correct doses of their medication.
Yeah. Thank you for that. It reminds me in many ways. I'm originally from Strawberry Plains, Tennessee, and I grew up on a family farm. And my grandmother would always use like the herbs in the garden, and she'll be like, "Go out and pick this, go out and pick that," and we'll bring it back to the house, and she would come up with these concoctions that she would, make us drink, make us eat. But the whole concept behind that was preventative, right? You need to eat this, you need to take these vitamins, you need to eat these vegetables so that you're able to prevent these conditions coming forward. So we know the answer to the problems that we're having is really investing more in preventative care. But we also realize that the system that we're currently operating in doesn't want us to operate in that way. There's been some questions coming in through the Q&A that I have been checking. And I kind of want to shift the conversation a little bit to address one of those questions that came up, and it's in perfect alignment with kind of our next kind of area of discussion related to peer substitution as systemic neglect. So, what are the risks of using fellow incarcerated people as interpreters, medical aides, or decision makers?
Yeah, so I can speak to that. The risks are high for a number of reasons. Obviously, we've talked a lot about privacy, and relying on another a fellow incarcerated person to do an essential job is also limiting people's right to their privacy. So in the hospital setting, this is something that we actually are trained as providers on, that we really shouldn't accept a translator or an interpreter um, uh, uh, who's offering to do it, but is not a certified interpreter. And that's because one, the privacy issue. Two, medical terminology doesn't always translate very well into even somebody who's 100% fluid in whatever sign language, Spanish, Portuguese, whatever it is they're speaking, doesn't always translate that well. And so there can be wires crossed, information that's misunderstood. And so making sure that you're actually providing high quality translation services is really important. Interpretation services is really important. I think those were the two main things. And then obviously putting the people, the people who are doing the interpretation themselves at risk too, learning information that they don't want to know for whatever reason. What happens in healthcare visits is spans many, many topics. And so it's really, it should be a professional who's in there who is able to sort of be there and then leave and not really have any ongoing relationship with the patient.
Right, right. Dr. Andres, anything to add?
No, I won't add anything to
Okay.
that question.
So we kind of started at the beginning of our conversation, and there was this word, Dr. Hawks, that you mentioned, and my ears kind of perked up a little bit, and it was related to accountability. And so we have systems in place that, if were followed appropriately, if the laws were actually followed and lived up to, maybe we would have better outcomes. So when medical neglect happens to disabled people that are in custody, who is responsible and why is accountability so rare? That's a good one. That's like my Oprah moment.
Yeah, you stumped me. Um, I think I think I gave my best answer a little bit ago, which is that there is no accountability because we rely on the courts to uphold standards and the courts are just way too efficient and way too unreliable. And so, certainly people can appeal. There's the Eighth Amendment, I believe the 14th Amendment, the Americans with Disabilities Act, and then there is one more piece of federal legislation, all of which can be used in a legal setting for folks to appeal for standard of care treatment. I can, if I pull up my book chapter, I can give you the name of the last law. But
If I could just jump into
yeah.
that comment, if you don't mind. It but the thing that is problematic with that is that it goes back to what you said earlier, that there's no body already protecting, there's not a governing body protecting the person, because we know that the 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 court system is favored towards people with resources. So if we're relying on an individual taking it upon themselves to file a case to get their care, and you also pointed out clearly that that could take 10 years, that is the that's going to be problematic. I mean, we need, it sounds, from the knowledge that I have, and that from being in the field, we need that more centralized governing body. And the Oprah question, which is definitely was a very difficult question to answer, but the persons who are accountable is the correctional system. I mean, it is, but they have to go, because it doesn't behoove them to be the accountable party. And that's, and they know that if they go to court, they know that an individual likely doesn't have the resources to really like, you know, battle them. So there needs to be a body protecting the individual, because the individual almost certainly, except for in these extreme cases that take extreme lengths of time, are you know you know the odds are against them.
Right. We're now at that point where I want to kind of transition us to the Q&A session. We do have questions that I will read out. The first question is coming from me directly, and it's not on script. And that question is, what's bringing each of you joy today? What's bringing you joy?
Okay, so I'm going to plug our own program here in coordination or connection with the community. Shannon and Beth are on right now. We are starting a program in the Wisconsin State Prison System to train people while they're still incarcerated to become community health workers. So this is sort of helping build the sort of healthcare workforce in the carceral setting to help people empower them to understand the basics of community health work, which is basic health education, health service navigation, and needs navigation. So we believe, I said this before and I was wrong, but I believe we're the first community-based organization, not correctional organization, that is implementing a CHW program. In a correctional setting or carceral setting, and so we're like kind of just getting started with our first in-person cohort, and hearing the stories from the students and reading their applications was really joyful, and just learning about the enthusiasm that people have, whether or not they're incarcerated, to care and be part of somebody else's healing.
Yeah, I think what's bringing me joy, in this moment in my life now is just is fatherhood. So I have my 7-year-old daughter with me. I have a 4-year-old son as well. Um, and just yesterday, uh, my daughter was doing a yoga class, and the instructor was telling me how she is a leader, and she helps others in their like positions. And we've had her art teacher tell us that she, is, walks around and helps people who don't understand certain things. So I mean, that brings me great joy to see that that she is like not just being a leader, but being someone that um, seeks to be a servant and help others. So I would say fatherhood is what's bringing me great joy.
Thank, thank you. Thank you both for sharing that. One of the questions in our Q&A comes from Amanda, and she asks, how do we have more compassionate releases for cancer individuals? As a hospice worker, that was so tough seeing people die while incarcerated.
Yeah. Um, our lack of access, or people's lack of access to compassionate release programs in this country, is one of the many, but probably the most heartbreaking injustices of our correctional system, is that many people should qualify for compassionate release for various reasons and don't. Because there's just the bureaucracy and this and the and the stigma, and the discrimination is so high. But hearing stories from both physicians who have advocated for compassionate release, and oftentimes unsuccessfully so, and from patients themselves, is definitely very it's one of the areas that I think that we could do a lot better on. So I thank whoever that person was for their work, because providing people dignity at the end of life is one of the most humanizing things that you can do.
Thank,
Yes, thank you. If I could just quickly add, I'd be curious and would love to connect with that person who asked that question. In the state of Maryland, we just passed, I mean, not me or our organization, but the state of Maryland just passed legislation. I know a lot of people that are working on this, but we passed legislation that that increased compassionate release medical release. But the challenge that we've now faced is we are in the process of doing work to get these people into get these individuals who are being released into the proper care, like a nursing home facility or end of life facility. And some of these places are private, some of them are pub or government state run facilities, and they're denying the individual, so they don't. There's the stigma of incarceration, even though that this person is at the end of their life here. um, they don't want people from prison in their facilities. So that is this interesting dynamic that we're looking to navigate. So would love kind of some ideas on how we might navigate that from that individual that asked that question.
Okay, thank you. Amanda, you have your homework. Reach out to Dr. Andres. Another question comes from Abigail. She states, a lot of these topics are new to me, so apologies if this is a silly question. If someone can source outside funding, family, GoFundMe, etc., is it possible to get appropriate on-site care for medical needs, or are there likely to be DOC prohibitions against outside providers coming in?
Yeah, I mean, sorry, did you want to jump
You
in
go.
first?
You go.
So what I can say, and Dr. Hawks, you could maybe add on to this or clarify it. The companies that come in to contract and provide medical care, they their contract does not allow any other provider to provide care at the facilities, even private, as the question is asking. So I would imagine that these, and they do that because they basically have a monopoly. So no other provider, these, and as was Dr. Hawks mentioned earlier, that each state has kind of its different contracting provider, but a lot of these providers have numerous like malpractice suits against them, but there's not a governing body to really do anything about that. So they're not providing the proper care. And they also have a contract that doesn't allow any other providers to come in. So I don't know that that could be allowed because of the way most of the contracts are set up in that way.
Yeah, I agree. I don't think that no matter how many resources you had, I don't think that you would be able to provide access to care for someone who's currently incarcerated.
Thank you for that. We've come to the close, but before we head out, are there any final parting words that you would like to share with our attendees today?
Oh gosh. Stan, do you want to go first on that?
I would just encourage all of us to really care for one another and seek to understand um, our differences and see the value in them.
It's hard to beat that. But it sounds like just reading the chat, I wasn't able to really read everything, but there's people doing amazing work on this call. So keep up the good work, and hopefully some collaborations can build from this conference.
Thank you both. This has been such a delightful conversation. I appreciate all the attendees that have been able to join us today. Please take a moment to complete the evaluation, and I look forward to seeing you at the next session. And I'm going to turn it over to you.